the recording, and I'll share your email if I can find the bloody thing. Come on. Where's that gone? Let's try taking it out. Try it again. The screen, and there you go. Okay, what he said was, I was just thinking about end-field palpation when we were assessing for subluxation. Let's say the innominate is sublux in extension. Would you feel stiffness in both extension because it's already stuck at the end of range, and in flexion because it's stuck and it can't rotate into flexion? Also, side question, how do you correct a medially or laterally rotated innominate? Okay, so especially when you're dealing with spines and joints that don't have a lot of movement available to them, but it does apply to the peripheral joints as well. These subluxations are typically not in the physiological range. Now, we talk about the SI joint getting stuck in flexion or stuck in extension, but it's probably stuck in one of the rotations, medial or lateral rotation, and it's that loss of that conjunct rotation that loses a primary movement. For example, if the conjunct rotation for extension is medial rotation and the joint is sublux into lateral rotation, then you're going to lose extension because you can't get the medial rotation, you can't get the inner range of extension. So usually it's not in a principal movement, and this is even more so in the periphery. Now, remember what we're talking about here. We're talking about models, not facts. All right, so we're just trying to find something that works for us. In the periphery, if you think about the elbow, for example, where you got a huge range of flexion and extension, you don't lose the whole range. So it's not reasonable to say that the ulnar humeral gets stuck in flexion, because if that was the case, you would have 0 degrees of extension. Okay, now let's take that scenario first. It would mean that if I tried to push this into extension, the sublux position, the end field would be normal. Now I'd lose range into extension because it's already jammed there. So it's already at the end of range. So there's no more available movement to an extension, but the end range or the end fill would be normal. So given that this is what you're really looking at, it's the end range of motion via the end field, this is okay. But in a big joint like the elbow, you'd realize that the whole of the extension range was missing and the whole of the flexion range. So it's not a reasonable model to say this is stuck in flexion or extension. If we're talking about extension, it's more reasonable to say that the ulna is stuck in lateral rotation and it can't fully medially rotate, which means that you lose the end part of extension. So the bulk of the extension is present, but you're missing the extreme of range where you need the conjunct rotation, and you get that from the end field. Is that okay? So in the spinal joints, it's even clearer. Because there's so little movement, I'll draw this as well, but because there's so little movement, this thing gets stuck there. And I don't believe it's stuck like that. It's probably caught off at an angle, but let's say it's stuck in flexion. Then you really can't feel. If I take it from neutral and I want to glide this into flexion or extension, and it's mobile in both ranges, I'm not going to feel that movement. There's a millimeter or two of gliding available, and you're not going to feel that. If you had bare joints, just a cadaver joint, you could probably feel the glide. But given that you're doing this through skin, other joint movements, everything else, you're really not going to feel the gliding. What you feel is the resistance to flexion or extension. And the end field tells you whether that resistance of the range is normal or abnormal. Is that okay? So it gets stuck in flexion. When you push it into the sublux position, into flexion, it feels relatively normal. Maybe a bit looser than it should be, a bit softer than it should be because it's overstretching things. But qualitatively, it's normal. Quantitatively, it may not be, but qualitatively, it's fairly normal. It's when you try and take it out of that range, it can't come out of it. And that's when it feels jammed. Now, if we look at the SI joint, which is what you're specifically asking about, as I said, basically, if this is stuck in its conjunct rotation or the conjunct rotation, you're jammed into one of the conjunct rotations, then your problem's got to be the range that requires the other conjunct rotation to be full range. Otherwise, you're going to lose that movement. Now, the SI joint, the amount of movement available isn't very much anyway. So you're not going to notice any loss into the sublux position, but you are going to notice an abnormal end field when you try it. So when you actually test extension, you can feel the bad end field when you try and get extension, but you'll feel that one or other of the rotations will also be jammed as well. If the conjunct rotation isn't jammed, you have to wonder whether or not you've got the right diagnosis. Is that all right? So again, if we look at this, can you all see that okay? The whiteboard?
Yeah.
Yeah. Okay, so this is the model we used. We had this, didn't we? And we had the anatomical barrier to movement, the ligaments, the joint, whatever. And then we had the physiological barrier, which is basically the muscle. So we have this arrangement, and normally the joint will move between the two physiological barriers and usually doesn't get to the anatomical range. And this is, your neutral zone is somewhere in this region, but your end zones are, generally speaking, the physiological ranges. And as soon as you start encroaching on the anatomical barrier, because the physiological barrier is breached, then you start getting Charcot joints. So when the muscle loses its controllability, then basically you start getting degeneration of the joints. So the model we used was that this joint got stuck here. We'll say that's flexion and that's extension. And the joint got stuck in flexion. So when I push it into flexion, the end field is relatively normal. When I try and take it out, it can't go, and you pick up that abnormal end field. Does that make sense?
So would it be like a hard end field?
Jammed.
Okay.
Jammed. It's not bone on bone. It's not that dead bone on bone feel that you get, say, with elbow extension when you pronate the forearm. It's not as dead as that. It's not as definite. There's a certain liveliness to it. And I think the example I gave you was the index finger. If you actually do the conjunct rotation of flexion and twist the finger towards you and then try and flex it, and then twist it away from you and try and flex it, you get two totally different end fields. And actually, in that case, you get two different ranges of motion. So, okay, but everything is happening at one end of the range. This one's fine. You can do like, providing you get to there, you're fine there. There's nothing to stop you coming that way. It's coming out of the subluxation where you run into trouble. Does that make sense to everybody?
And would the end field be, so if it's subluxation to flexion and you're trying to flex it more, is the end field different than if it was more neutral and you're pushing into flexion?
Well, no, not as far as quality is concerned. If it's a capsular end field, it remains a capsular end field. But it may have overstretched things because it's jammed at that end of the range. That might be a bit hypermobile in that range, so the end field may be softer than it should be.
Okay.
So if you go back to this again, your two barriers, it's stuck in here. So this is what it tends to push against, and it can stretch that out and change the quality of the end field. But the end field doesn't change in, sorry, it changes in quantity, not in quality. So the end field doesn't change its quality. If it's capsular, it's quite capsular. What changes, if it changes at all, it's the quantity of the end field, not the quality. When you come back this way, though, it's a completely different end field to what you would get if you managed to get back, well, back to that point anyway. Is that okay?
Sorry, any conjunct movement with extension in the SI joint is medial rotation?
Normally, yeah.
Okay.
Yeah, like if you're taking a step forward, everything's about function with closed packing and so on. If you're taking a step forward, the innominate extends, all right? So it anteriorly rotates as you're stepping forward. Now, the whole lower limb from the innominate down medially rotates. Everything it does. But if we're talking about pathomechanics, I don't think you can predict what it is. So basically, if you're finding it sublux, if you're missing extension, with normal mechanics, you would argue that basically if it's missing extension, it must be missing medial rotation, but you're not. You're dealing with pathomechanics, so it could be either one, medial or lateral rotation. And I think one of the things that tends to do is show you whether you're dealing with a primary or a secondary subluxation. So I think if this is subluxing because you have a long leg, for example, let's say the hip can't extend, then you're going to overextend the innominate and the lumbar spine. We're concentrating on the SI joint. You're going to overextend the innominate to get more stride, because the loss of hip extension reduces the amount of stride you've got. So that's going to over-rotate the innominate. And because that's happening in walking, in gait, that will tend to sublux it into medial rotation. If this is a primary subluxation, though, that the joint has been subluxed by some force, it's degenerated and it's changed all the mechanics. So if this is a sudden force on it after it's been degenerated and unstable, then it may well laterally rotate as it goes into extension. So I think all you can say is that if you find that you've lost extension, either medial or lateral rotation will be lost. I don't think you can necessarily say which. You can post-dict the cause of it by whether it's medial rotation or lateral rotation associated with a loss of extension, maybe. But I don't think you can predict what you're going to find. Is that okay?
Yeah, thanks.
Okay.
Jim, quick question.
Mm-hmm.
So when you say you step forward, basically what you're doing is a hip flexion. So when hip flexes,
No, I'm not talking about that. I'm talking about from
innominate extension.
Yeah, I'm talking about from where your weight-bearing foot is planted and you're coming over the top of the leg. So as you're stepping forward and you're coming to heel strike, the whole leg is laterally rotated and the innominate is also laterally rotated and flexed, posteriorly rotated. When you hit the floor and you start moving over the leg, that's when the whole leg starts to medially rotate, and it will be maximally medially rotated just after mid-stance, when you start to transfer the weight forward and before your heel comes off. Okay.
So it changes when it's open chain. This is a closed chain.
I don't know that it does. Like if you bend your hip, if you bend your knee up in non-weight bearing, then you'll get posterior rotation of the innominate and lateral rotation. If you lie on your stomach and extend your leg in non-weight bearing, you'll get extension of the innominate, anterior rotation, and medial rotation again. So it's just that when you're weight bearing, the amount of forcing it's going through it are so much greater than when you do it in non-weight bearing.
Okay.
I think like weight bearing and non-weight bearing, open and closed chain is important when you're talking about the foot. You can't pronate the foot when it's not on the ground. You can't supinate the foot when it's not on the ground. You can invert it, but you can't pronate and supinate. It needs your body weight to split the foot in half. So you've got medial and lateral rotation going through the foot. That's important for the foot. I don't think it's that important for the rest of the leg as far as the conjunct movements are concerned. Okay.
Makes sense. Thanks.
And also understand, having said that about getting pronation and supination weight bearing, you can invert and evert your foot in weight bearing.
Yeah.
As well as pronate and supinate. All you got to do, if you twist on your feet, one foot is pronating and one is supinating. So the contralateral foot is pronating, the ipsilateral is the contralateral foot is everting and the ipsilateral foot is, let me do it again. Yeah, the ipsilateral foot is inverting.
Inverting.
So when your body goes over the top of the foot, it splits it in half. Or not quite half, but close. Down through the third metatarsal. Okay. Leo, you had another question. about facets, didn't you?
Yeah, and that's how they assess for mobility in the facet joints in the cervical spine.
Okay. Well, your P-PIVM is your screening test. So you side bend, translate, inflection, and extension. Okay. Now, from that, you get an idea of what joints can be involved. So these are your three joints, the facets and the unconvertible joint, and you're going to do left side bending in extension. It really doesn't matter, but you're going to do it in extension now. So you're looking at the back of the neck. So I extend it. These two joints come down, yeah, there. And nothing much happens around the unconvertible joints. When I left side bend it, this one has to come further back and this one has to return to a more neutral position. So this one has to be able to stretch its capsule. This one goes down and that one goes up. Is that okay? Now, if this can't stretch its capsule for any reason, the muscles holding it, the unconvertible joints, it doesn't really matter. But if I can't left side bend and extension, then the joints that are involved, maybe involved in this, if it's not muscular, is that one, that one, or that one. The one that can't do it is that, because that's simply moving back to a more neutral position. Does that make sense?
Yeah.
Okay. So when I assess the facets, basically you glide them. Now you've gone from the P-PIVM, which is the screening translation side to side inflection extension. Then you do the PAVM. So for the facets, for extension, you push the articular process inferiorly. Now that's inferior down the back of the neck. Is that okay? If I want to assess flexion, I'll pull it up the back of the neck. Now, if it's a U joint, I'll push the ipsilateral one to the side bending loss down the side of the neck. And the other side, for a superior glide, I'll push the lower vertebra down the side of the neck to simulate the upper vertebra coming up. Is that okay? So the PAVM, the difference in the PAVM between the U joint and the unconvertible joint, sorry, the U joint and the F joint is 90 degrees. It's a plane that you're pushing the PAVM. One goes down the side of the neck, the other one goes down or up the back of the neck. That's it.
So even with the musculature in the back of the neck, can you still hook your fingers onto the particular pillars and move the facet joints?
Well, if you're doing flexion, you have to try and pull it up. Now you could, in flexion, stabilize everything and push the inferior one down. Okay. The problem with doing that is there isn't. Yes, there is. It's stabilizing this properly because I've got if I'm testing the right joint for loss of flexion, right translation, I have to hold that right translation on. And then I have to stabilize it with the one below it, pushing it the other way. And then I have to try and push that one down as well. It gets a bit difficult. It can be done. And in fact, that's exactly what you do with the manipulation, that simple flexion manipulation. You just shove it down downwards rather than pulling it up. But you can do it that way. So you can either pull the superior facet up or you can push the inferior facet down. That's for flexion. Extension is really easy. That's lift, shift, and shove.
And are you using the tip of your finger to push it down, or are you using the
For
web?
testing, no, you push it down with your finger and pull it up with
The
your
fingertip.
Yeah. So you're just doing that with it. Yeah. When you manipulate it, you're going to push it with that bit. But this is where your sensation is all here. So you'd be silly using part of the hand where the sensation's less.
Yeah.
All right. Okay. Anything else there, guys?
So Jim, when you were teaching first U joint manipulation,
Yeah.
and then last course, I'm talking about Edmonton. Last course, when you say this, when this glide fails, things were slightly different. So you said you can't change the hand position. So
No.
I didn't understand that concept. We can actually do this, can't we? So first you
Well-
taught the glides where you say, let's say you have to do superior glide on right U joint.
Yeah.
You push the inferior vertebra inferior.
That's to manipulate it.
Manipulate. Yeah, I'm talking
Yeah.
about manipulation.
So what you're doing is you squeeze the neck.
Squeeze them, yeah.
That's right
And then-
translation for the right joints. You squeeze the neck.
Yeah,
That gives you really good stability and purchase.
yeah,
And then you have to put this right up on that and push down, which
Yeah.
is okay for the manipulation. It's just more difficult to get them squeezed together and just palpate the movement.
yeah.
It's more difficult to do the test than it is to do the treatment. For me, it's easier to pull the superior vertebra, the superior facet up rather than to push the inferior facet down. I'm not saying you can't do it. I'm just saying it's more difficult to do.
It's more difficult. Okay.
Yeah.
So in the U joint, if we have to do superior glide, let's say C4-5 level,
Yeah,
and if you want to do superior glide on the right side,
yeah,
so basically left translation is limited. So you bring
Yeah.
right side flexion, right? So
Yeah.
you squeeze the neck and then
Yeah.
you push the C5 inferiorly to get
Yeah.
the U joint. So C4 superiorly. Right?
yeah,
And when it comes to same way, anterior and posterior glide,
yeah.
if you want to do posterior, you just squeeze it and then you can do posterior on the transverse process of C4. I'm talking about U joint.
Yeah, but you're talking about the superior glide or the inferior glide now?
I'm talking about the anterior and posterior.
Yeah, but superior or inferior glide missing.
Yeah, so that I still don't understand.
All right, look, you don't worry about the anterior and posterior glide until the inferior or superior manipulation fails.
Oh, I see.
Okay, you just don't do it. There's no point.
Okay.
So after you try the inferior glide and it fails, then you have to check the anterior and posterior glide on the joint you've manipulated, and
Okay.
then manipulate that.
Okay.
Okay, but you're not going for that first. You do the superior and inferior glides, so you know what translation you're dealing with and which joint, left or right joint.
Okay.
All right.
Yeah. Yeah.
Otherwise, it gets really confusing because you're doing the wrong testing. If you wanted to treat the anterior or posterior glide first, your testing would have to be done with rotation,
Yeah.
not side flexion translation, and that's not easy to do. Rotation is never an easy thing to test in the spine.
Okay.
So
So you go superior and inferior first, and if they fail, then you can
then you look
check
at anterior,
again and
posterior.
then see if you need anterior or posterior.
Yeah.
Got it.
Okay. Got anything else? Everybody good?
One more question about the capsular end field. So if I'm remembering this correctly, you said when there is a capsular end field, you don't want to mobilize that, right? It's only when it's jammed you mobilize.
Manipulate.
Oh my bad. Manipulate.
Yeah. The only exception I can see to that is the hip.
Oh, okay.
And if you get a lateral rotation subluxation. So normally when you get a subluxation of the hip and you do the lateral glide, normally that's fairly normal. It feels pretty normal. Every now and then it'll feel stiff. So I think what you're dealing there is with a stiff joint that isn't stiff enough to limit lateral and medial rotation. Certainly lateral rotation, because that's the direction it's going. So under those circumstances, if everything is right for this to be subluxed, except for the end field, which is hypercapsular, then I would manipulate and see what happens. Okay. And I think I said this to you. End fields are dodgy, they're iffy. There's no end fill is capsular or anything else. You got to remember this is a composite end fill, and especially on normal joints, it's very much a composite end fill. So what I think I said to you was there is so little value in trying to mobilize a stiff joint. You just don't do long enough at it. you might as well try and manipulate it and see if it works. And it's basically what you're doing is I'm assuming that I've misread the end fill, so I'm going to manipulate it.
Yep.
You're not going to do any damage, and you never know, you may be lucky. Yeah.
And if that doesn't fix,
Well, if they've got hard capture, if they're arthrotic, they're screwed.
Okay.
Especially in the spine. Like I can give somebody, if somebody's gone over their ankle, they've got adhesions there and everything else, I can give them an exercise that will stretch out the capsule, and they can do that safely. You can't do that in the spine. If I've got C5, 6 that's arthrotic on the right, and I give them an exercise that's doing this, the other joints have to go through the same movement. So you're in trouble with it. You know?
basically spinal joint mobilization don't necessarily work well.
It doesn't work to directly increase range of motion. What it adds is a strong neurophysiological effect. So it decreases pain, improves tone. So you will get more range of motion. I'm not saying this is pointless. I'm saying to actually structurally change the joints with manual therapy is pretty much impossible. And to be honest with you, I'd rather stick a muscle stim on them and go and do something else. But that's me. Lazy sod.
Yeah, thank you.
Okay. Anything else? Did you all get the links to the exam?
Yes.
Okay. James, can I get you to do something for me?
Yeah.
Can you try and get on that page? Now, you don't have to actually log your name in, but I want you to get to the point where you would put your name and the password in. So if you go through the initial steps, but don't log in with your name. I know it works. Okay.
Yes.
Okay. Shira, can you do the same thing for Edmund?
I already did it and it does work.
Okay, good.
But I didn't log in because it will start taking the time, right? So,
Yeah.
okay.
And if you log in, you can't log in again, basically.
Yeah.
So good. Yeah, James, did you try it for Calgary?
Yeah, you betcha.
Let me know it's okay. Good. Because I can't rely on mine because I'm all booked in and it knows me on my computer. So I'm never sure if that's telling the truth or not. Okay. Well, I'm running out of things to talk to you a lot about. So it's a 30-minute.
How many questions again, Jim, is the test?
58.
Okay.
58. Yeah, you got something like 5 hours to do it. You want to.
And it will be till 11:59 p.m. right on Sunday
Yeah.
for Calgary.
Yeah, you're starting on Saturday AM, aren't you? 12:01 AM or whatever it is. Yeah.
Okay.
Yeah, that'll run for the full 24 hours.
Perfect.
Don't
And
go
Jim,
on and come
envy-
off. All right. If you book off, it's not likely to let you back on again. All right. If you need to do it again, you can, but it's under a different name. You have to use somebody else's email address. But don't do that without talking to me, okay?
And the questions just like the ones you sent on October.
Yeah,
4th?
pretty much.
Okay.
Yeah. And remember that you need a pass mark of 56% on that written paper. That means you've got to get 100% on the diagram. All right. If you get less than 56%, you can't pass it, essentially. If you get 56%, you need a perfect diagram.
What was the lowest mark on the diagram?
The lowest mark on that is, well, if you got, let me think, the diagram's worth 20%. All right. So if you hit 80%, I think that's right. It depends on how well you're doing the thing. If you hit 100% on the written paper, then the diagram becomes unnecessary. Yeah. And I haven't done the math on this, so I don't know. It's not difficult to work out. I just can't work it out. I assume it would be you'd need 80% if you got 0% on the paper, I would think. Sounds right, does it?
Oh, have you marked the diagrams yet?
No,
Oh, okay.
no.
Jim, for the Edmonton, it will be on Sunday, right? Last day?
I can't remember. January 8th, wasn't it?
No, January is the written exam. So on the very same day we'll do the diagram, or
Yes, on the Sunday, next Sunday.
oh, you're talking about the practical exam, same day, last?
Yes.
Okay, okay,
Yeah, so you do the diagram on that Sunday lunchtime.
okay.
All right. Yeah. And that, generally speaking, takes, I think everybody, in Calgary, I think everybody got finished within about 15 minutes, didn't they?
Mhm.
Yep.
Yeah. I'll do the diagram again Friday morning. The only thing I'm not going to let you do is copy the diagram and have it open when you're doing it. All right. Okay, we done?
Couple more questions, just a
Yeah.
second. I'll written it down somewhere.
You know now you're hated by everybody else, aren't you? Including me. Well,
Jim, can we do the questions if possible?
you want to keep on doing them? I thought we did them all.
All of them we did?
Probably. Have you been through them?
I have been through that. Yeah. I just need to ask only one. I know we have done, but I'm just confused between two options. That's why.
Sure, if you got a question from it, ask me.
Uh
But I
so
haven't got
it
it open
was
in front of
number
me.
29. It is which of the following characterized by a pseudo-aneurysm? So the option was ballooning out of all three layers of artery, ballooning out of adventitia,
Yeah.
ballooning out of adventitia and media, and the fourth one is an inward ballooning of intima.
Okay. So this is an aneurysm, a normal aneurysm. It's a weakening of the arterial wall, and that's what happens. So the other side's over here. Okay. With a pseudo-aneurysm, a pathological pseudo-aneurysm anyway, is you have a tear, and it has to involve the intima and media. So this is your other wall. So this tears like that. So there's your tear, and this is coming down here. And the adventitia remains intact. And it's the adventitia that balloons out because it hasn't got the muscular coating. So the aneurysm is a congenital issue. This is just weakness of the wall. It's been there forever, or it's developmental. This one, though, is traumatic. So the pseudoaneurysm is a ballooning of the adventitia.
Oh, okay.
All right. If the media is intact, you won't get this.
Okay. Yep, that's it.
Okay.
Perfect.
And it's not so much you don't get an internal ballooning, but what you can get is this. If the intima is torn and or the media, what can happen is this there. So the blood goes up here and it strips it away from the wall, pushes it off the wall, and that can actually act as a valve. So it can block the flow through there. And the problem then becomes is that all of the blood goes up between the adventitia and the media, or the media and the intima, depending on which is torn. And you don't absorb oxygen from it. So basically, it's pointless. And the Doppler will show this is flowing, but the flowing blood can't, the oxygen can't be resorbed because only the intima can absorb the oxygen. So, but that's not an aneurysm. That is basically the inner linings blocking the artery and stripping away from the wall. Now that stripping away will lead to an pseudo-aneurysm, but if that doesn't blow out, which it doesn't if it's the intima, and the blood gets up between the intima and media, then yeah, but that's not an aneurysm. Okay.
Thank you.
Okay. Are we going to get the questions beforehand for the win? No,
What questions are we discussing here? I don't.
the written exam. You've had them, you've got them.
Was it? Okay. I didn't check it, maybe.
You've had these for, we've been doing this now for weeks.
Okay. I didn't actually see all the Zoom sessions, so I'll wait for.
Have a look at them. All
Yeah.
right, because this is the last, what's it been, 4 or 5 weeks?
Yeah.
We've been doing nothing but these questions.
No.
You should have, you should have, the paper you've got is a sample paper. It's not the one, it's not exactly the one you're going to be doing on the exam,
Okay.
right? But they're very typical of what you are going to get. And some of them are going to be the same. Now you've got that paper. I sent that out to everybody.
Okay.
And we spent the last 4 or 5 weeks going over these questions. So yeah, look at them.
Okay.
All right. Hi, Tolu.
Hi, Jim.
We're just finishing. Have you got any questions?
No.
Okay, well, welcome and goodbye.
Jim, one question about muscle stim and TENS. You said you would rather use muscle stim
Yeah,
than TENS.
Yep.
And is there any particular reason why you choose muscle stim over TENS?
yeah, because the proprioception you're getting from it is proprioception. It's not just the electrical signal. So the 10 signal is more well-defined, more refined to give you that pain reduction. But proprioception does exactly the same thing. So when you're using muscle stim, you're moving the muscle, you're moving the joint, and you're getting real proprioception. So this isn't the electrical signal that's doing this to any great extent. It's actually the proprioception coming from the body tissues. So I'm not sure which is the better of the two, but I do know that when I want to shift from pain control to muscle stim, deliberately trying to stim the muscle, I can do that. Then it's just a continuation of that. Whereas if I try and get somebody who's been having TENS and then try and give a muscle stim, it's a bitch and a half. They panic. It's contracted. Oh my God, it's contracted. What's it doing? So I don't use it.
Yeah.
Don't use it.
So
The
if
only
someone-
time I use TENS is for a TMJ problem if I want to put it there.
Yeah.
Because I don't want to stimulate the masticatory muscles. I like TENS to be fairly high. And if you're using it high enough, then you've got muscle contraction. I don't want those masticatory muscles stimulated. But no, I actually do dislike TENS. I don't think it's that effective.
Okay.
Whereas I think I like the stim.
If some clients, you say if it's the proprioceptive effect we are targeting on, if someone doesn't have muscle stim at home, but they have a percussion massager, does it give the same proprioception to the joint? Do you think so?
No, I don't think so. Muscle, like massager,
No. Oh yeah, percussion massage, the gun, massage guns.
I don't think it does. And I think the other thing with the muscle stim is you really do want to get these muscles contracted. So the stim has the advantage of avoiding exercise. Like these patients are not going to do the exercise that you give them once you've discharged them and the pain's gone. They're just not going to do it. Whereas if they use a stim every couple of days or so, they'll keep the muscles active. Whereas a massage unit won't do that, and neither will TENS. So there's all sorts of reasons to use stim over anything else, including manual massage, which I think is a real waste of everybody's bloody time for therapy. It's okay if you like it, but as a therapeutic tool, I really do think it's a waste of time. And this is from somebody who spent 6 months learning how to massage. Yeah. Never did like it though. Never a fan of it. I don't like it being done to me, let alone me doing it to somebody else.
A question about ultrasound. You said you like to use it for acute inflammation sometimes if you
Yeah.
can't do anything else. Can you just confirm you said you want unpulsed ultrasound, meaning 100%? Or
You can, if you're
pulsed?
going to use pulsed ultrasound, don't move the head.
Okay.
All right. You've got to remember the size of the area that's inflamed is tiny. The center of the beam is only about that big anyway. So you're moving it on and off, and the thing's not getting any sound. This is why it doesn't work. So if you're going to use pulsed, hold it still and get the dose up. If you're using unpulsed, then what I tend to do is either not move it or move it in very small bits, or turn the intensity down as they start complaining about it. You can't leave it on high. You will burn them.
Yeah.
But otherwise, pulse it, hold it still, unpulse it, move it a wee bit, or just keep adjusting the intensity.
Okay, so then for pulse, do you go 50 or less than that?
Intensity?
No, 50% for pulse.
Oh, what work cycle?
Yeah.
Well, you've got the same thing going on. The lower the work cycle, the frequency of the work cycle, the higher the intensity has to be.
Right.
This is about, like, a lot of this is paranoia. When I went to school, they just discovered that you could actually cavitate nerves and bone with ultrasound. And the machines then were putting out 7 to 10 watts, I think it was. And when they discovered that, everything got adjusted down. So now it's 3 watts. And they were completely paranoid. I remember the first time I did it. And I actually had a supervisor walk past me. I never saw supervisors except this first time. And she walked past me and she said, move the head, you're going to burn them. So I'm all of a sudden, holy shit. Now I'm doing these big swathing movements. And it's because of all the paranoia. It's set now that 3 watts is not going to cavitate anything, but it may burn somebody, but it's not going to cavitate anything.
Talk about 3 watts per centimeter squared.
Yeah.
Oh, for pulse.
No, on solid as well. Apparently it's not high enough to cavitate, but it is high enough to burn. You can get periosteal burns and stuff with it. So it's very rare for me to go at 3 watts, very rare. I mean, a lot of these machines now only go to 2 watts.
I didn't even know I can go to 3 watts.
Yeah, but the 2 watts are fine. But you give high doses by keeping it still or not pulsing it.
So you're saying only the total energy matters in the end?
Yeah.
Okay.
Yeah. Yeah.
So if we go, say you do 50%, then typically what do you use then?
I double the dose. If I was using unpulsed and I was using 1 watt unpulsed, then I brought it down to 50%, I'd probably put it on 2 watts.
And just
But
leave it in
still
one
comes
place.
down to the patient. If the patient complains about it, then move it or turn the intensity down.
Yeah.
You're reacting to the patient.
Okay. And what does the literature say about the total watt or energy you should deliver per treatment?
How much should you give them? I have no bloody idea.
Oh, okay.
I don't know. I don't know. I would think probably, given the time constraint you're doing this, and I think you need at least 5 minutes, at least 5 minutes. And I've done 10 minutes. I don't know. It's not difficult to figure out, is it? But I just don't feel like it.
Okay.
Like, it's not just a matter of cross-sectional area, it's a matter of watts per second as well. I have no idea.
Does it change with the depth of the tissue you're treating? Because they say 1 megahertz versus 3 megahertz.
Yeah. Yeah, the higher the frequency, the deeper it goes. So you've got these, and it's all about half distance values, isn't it? So you lose half of it over a given period. So use higher intensities if you can. Usually if you're going through muscle, it's not a problem. Because you can get the intensity up higher. Just don't move the bloody thing. Like, I don't care what frequency you're using. If you're scrubbing this thing over a 6-inch swathe, that is not being treated with ultrasound. It's just not getting any. And then to actually do it pulsed and then still move it is ridiculous, absolutely ridiculous. And then what do you get? The schools telling their students that ultrasound doesn't work. Well, if it doesn't work, stop teaching it and tell them that. But they don't stop teaching it. And it does work. You can get these machines where you can actually put them on the patient and walk away and leave them. Now, the thing is pulsing because it rotates. So you can walk away. And I had one of those years ago, like 1978, I had one of these. And you just put a weight on and walk away and live in 20, 25 minutes of ultrasound. And all of a sudden I was realizing this thing actually does work. You're getting results with it. So now if I was going to buy an ultrasound machine, I'd see if there was one I could leave in situ and go and do something else. Because I don't want to sit there and talk to patients. That's the last thing I want. I don't talk to my family, let alone bloody strangers, unless I'm in a bar.
I wonder how do you take history, Jim? How many questions do you ask? Where does it hurt? For how long? That's it, right?
Focus. It's all about focusing your questions. But the thing is, this comes down to the way you're doing your reasoning. If you're in pattern recognition mode, then it doesn't take very much at all. It's very quick. This is 20 seconds and you've got the diagnosis because you recognize the pattern. If you're not in pattern recognition mode, then if you ask every bloody question you can think about, you're going to be there for half an hour or so. And at the end of that half an hour, you're usually more confused than when you started, when you ask every single question you can. So providing you focus it on a hypothesis, you generate a hypothesis immediately, focus the question and the test on the hypothesis, prove it or disprove it and move on. Then things get, it mimics pattern recognition. And it's a lot quicker. You can turn around and say, I have no idea what the hell this is. Let me ask you a question I asked the group earlier. If you was examining a patient and you found weakness, say in the legs, or, not and, but, or you found sensory loss in the legs, which would be the most significant finding? Weakness or sensory loss?
Weakness.
Okay, we've got a weakness. Any other offers? Maybe I should put that.
I want to say sensory because there's if you have sensory loss, then you're, I guess you're almost certain that it's a nerve issue.
Okay.
But weakness can be caused by
Yeah,
non-nerve
neurophysiological
issues.
stuff. Yep. Yeah, that's exactly it. The sensory loss is definitely neurological. You don't get neurophysiological sensory loss, but you get neurophysiological muscle weakness. So that is much more significant than that weakness. I think the reason why you thought it might be the muscle is because you're thinking of function.
Okay. Yeah.
But that's not your problem. You have no idea what the diagnosis is, and you'll find one of these two findings, that the sensory loss findings tells you it's neurological. I got a bit pissed off. After the course last week, I went to stay with some friends. Sunday night, I had dinner and stayed over. And the wife was seeing a therapist for back pain. He was needling her. And he's doing what all needlers do. They've got nothing else to work with and everything gets goddamn needled. It drives me up the wall. If you're going to do a needling course, the one I would recommend is the one that Scott Gallant does, because he ties it to manual therapy as well. Otherwise, you get carried away with the needling and everything's about needling. Anyway, it did a good job on her. She saw him about a week earlier and the back pain had gone, but she got a sharp lancinating electric pain down the side of the right leg. And then she got a stinging pain in the front of her left lower leg. And then she said to me, I can't feel the legs now. Like touching them, I can't feel them. So I said, all right, give me a couple of pins with you. Now I'm doing this in somebody's living room. So I'm doing that. And as I'm putting the pin, touching the skin, she lifts the leg up and make it easier for me. And I managed to drive that pin probably an inch into her leg. But she looked at me and she said, I don't feel that. Now, I didn't do a full exam because it's somebody's living room and it's a friend, and I hate doing this with friends, absolutely hate it. So I said, well, you've got numbness in both legs. You need to see a neurologist. When you see a therapist again, so she said, tomorrow morning. So I said, all right, talk to him, tell him that we did this and you've lost sensation. So she came back from the therapist. So I said, so what did he say? Well, he didn't bother testing me sensation. He tested me muscles and they were okay. So he said it didn't matter. It really pissed me off. He's being told there is sensory loss there by another professional and he hasn't bothered to test it. And he carried on needling. This is what pisses me off. But no idea of what's important and what's not important. None at all. Anyway, she went to see her doctor and she's got really crappy spinal x-rays, lots of degeneration and osteoporosis on x-ray. So that's not good neither. And I said to her, all right, well, this is wear and tear and dried up hormones. I said, but I have no idea where this numbness is coming from. And I have no idea where it's coming from. So I said, you need, and the doctor said, we'll get you in to a neurologist. But if you don't recognize that sort of thing, when's she going to find out about it? You know, this is bad therapy. And the guy should be dragged up about it. It's very tempting to do something about it as well, but I won't. But it's just, he's probably no worse than 90% of the therapists out there, especially amongst needlers. Because everything's about, can I use a needle? Where do I put the needle? And not about the diagnosis. Rarely about the diagnosis. Sucks. Anyway, that's my bitch for the evening. Okay, we good?
Last question, Jim. Sorry
Yes,
if it's not too late.
that's all right.
So, so you told us about the ultrasound dosage because I don't use stim as much, but now I will start using it. So, what will be the doses you will prefer for muscle stim?
Oh, it depends on what you're doing it for. Like if you're doing it because the patient's too acute, for Edmonton, a Mal with her neck,
Yeah.
you got that really nasty reaction to it.
Yeah.
I would have, my next treatment would have been muscle stim on that area, maybe 5 or 10 minutes to see what it did. If that was fine, then I'll bring it up over a period of about 2 or 3 treatment sessions to 30 minutes. And you want the muscle contracting, and preferably you want the joint moving.
So, what will be your pulse width, and what will you go if it's acute condition like?
That is an acute condition. I would have treated that as an acute condition.
Yeah. So, what would be your pulse width and the
No, it's
frequency?
just, it doesn't bother me. You want a tetanic contraction.
Okay.
All right. Like you need at least probably 50 hertz,
Okay.
but you need a tetanic contraction. I don't get caught up in all these waveforms and
Okay.
frequencies. All I want is the muscle to contract, and I want it to be as comfortable as possible. So that's your parameters. You want it comfortable and as strong as you can get it.
Yeah.
So that's what you mess about with the parameters. You make that, you end up with that, a good strong contraction and the patient comfortable.
Okay.
All right. If I'm doing it for, if I want to do it because I've got a tendinopathy and I want to basically stretch the scarring, I can use an eccentric contraction with it as well.
Okay.
So for example, if I've got a tennis elbow, it pulls the wrist up and they pull down against it. So they're actually elongating the muscle under tension. It's an eccentric contraction.
Okay.
Lots of uses, lots of uses. Rehab, making the muscle contract because it's inhibited. Lots of stuff you can do with it.
Okay.
And mobilize joints. So I'll stick that on instead of standing there doing a grade 2 or 3. I'll stick that on and walk away. Yeah. All right.
So you're talking about NMES for mobilizing a
stim.
joint?
Muscle stim.
For mobilizing a joint?
Yeah.
How do you
Right.
do that?
Hmm?
How do you do that?
You just turn it up high enough so it moves the joint.
Okay.
You didn't probably hear a shockwave to mobilize the joint. That's why.
Yeah,
Okay.
shockwave to mobilize joint. But this one will do it. I mean, this is the whole point of muscle stim, that you want to stimulate the muscle so it contracts. That's why it's called muscle stim. E-stim is different. E-stim is any electrical pulse that stimulates the patient. This is muscle stim. It stimulates a muscle into a contraction. That's it. Turn it up high enough to get it. Don't be a pansy with muscle stim. Make it work. Patients generally like it as well. Takes a little bit getting used to it. And the thing to do is when you're setting it up, tell them that it's going to feel like it's going to cramp, but it won't. That's what panic them. They think it's going to go into a cramp. Just tell them it's going to feel like it's tightening, like it's going to cramp, but it will not. Now,
How
if
do
you
you know
turn it
that?
up high enough, you'll tear the muscle.
Yeah.
So as long as the joint's moving, you're okay. When the joint has finished moving, everything after that is dangerous. I use it for the quads. If you want to get post-exercise soreness in a muscle, the quads is a good case in point. You get the contraction strong enough that it will straighten the knee, and then you have them bend the knee underneath it. And now you're doing an eccentric contraction of the quads via the hamstrings. You'll end up with post-exercise soreness, which I assume is the same as normal post-exercise soreness, where you've actually longitudinally torn some of the fibers, which you now hope will hypertrophy. Yeah, it's the only way I know to get post-exercise soreness in muscle is eccentric contraction, electrically anyway, is eccentric contraction under load.
So you mean you're pushing their leg, you're bending the knee manually, or they?
No, they bend it. No,
Oh, so-
the stim straightens the knee and they bend it against the stim.
Oh, okay.
Yeah. So you're using the hamstrings to bend the knee, but it's the quads that are contracting eccentrically. Yeah.
Yeah.
I have arguments about that. Well, that's not an eccentric contraction of the quads. Of course it is. Isn't it? Just because the quads are, well, if I do a squat, the quads are not producing the squat. My body weight is producing the squat, but the quads are contracting eccentrically when I do that. In this case, the hamstrings are bending the knee, but the quads are still contracting eccentrically. All right, you good?
Yeah.
All right. Okay, see if you can find something for me to talk about next week, would you? I'm running out of options. We've been doing this now for how long? This is well over a year, isn't it?
We started last year, I think.
Whereabouts last year? I think we've been doing, feels like 5 years, but I think it's
Pretty
been a year.
much like September. Yeah, it's more than a year.
Yeah, yeah, feels like it.
Because the initial course was registered in April and then it was postponed.
Well, yeah, the first course was in 2020, or was it 2019?
Yeah,
We've cancelled the Edmonton. The Edmonton one's been cancelled 3 times. And
3
the Calgary
times.
one twice. Yeah.
Yeah.
Oh well, we're getting there. All right. So you, Chirag, look
Yes.
at the questions and look at the Zoom sessions. All right.
Oh, well, yeah.
Yeah.
Thank you.
Otherwise, there's no sympathy when you screw up. All right, guys. I'll get this out to you and everybody else. All right.
Thanks, Jim.
Okay,
Thanks, Jim.
thank you, Jim. Thanks.
Take care, everybody. Have a good
Okay,
week.
Thank you. Have a good night.
Bye.
Good night.